Hello, my name is Andreas Miramontes. I'm an undergraduate researcher in Dr. Daniele Rodriguez's Biomaterials for Osseointegration and Novel Engineering lab, and this project is the impact of residual dental cements on peri-implant disease development, a preliminary study in a rat model. So over 800,000 dental implants are placed annually with a global market size of over $4 billion. Dental implants are essentially structural and functional replacements for missing teeth that are utilized for endodontic applications, with components consisting of an implant body, an abutment, and a crown, with the most common dental implant material being titanium. Though dental implants may not be cytocompatible with peri-implant diseases and periodontal tissues, as even with high success rates in surgeries, there is still around 2 to 10% of implant failures occurring each year. Dental cements are eluting agents that are created and used for implant prosthesis retention, though there is a lack of preclinical studies evaluating dental cements as a primary cause for the development of peri-implant diseases, as realistically, up to 50 times the ideal amount of cement required can be placed. This practice has led to the residual cement to accumulate in the operating area, which may lead as a cofactor for development of peri-implant disease. The aim for this project is to evaluate the biological impact of excess dental cement on healed peri-implant tissues. So we tested between rats with a soft diet and a hard diet. We hypothesized that the presence of residual cement will disrupt the balance of the titanium tissue and lead to the breakdown of peri-implant attachment and inflammatory bone loss. Secondly, the soft diet might increase the chances of plaque accumulation and act as a cofactor for peri-implantitis development. I would like to draw your attention to Figure 3, as we can analyze the bone morphology of the craniofacial structure of the two different diet groups. The arrows indicate the reduced supporting bone for the soft diet group when compared to the hard diet group. For the methodology, we present 14 total rats, each about 12 weeks old, that are distributed into 4 groups. These groups being the negative controls for the soft and hard diets individually, which each consist of 3 rats each, so a total of 6, and then the implant plus cement groups for each the soft and hard diets, consisting of 4 rats each, so 8 total, with sham treatment being performed in the groups receiving the cements. So then, we first begin by introducing the dental implant, and then for the surgeries we insert the implant into the rats, and after 14 days to heal, a pocket will be formed, and cementation will occur afterwards. This way we can clinically evaluate the results of the surgery through micro-CT scans and analyzing the biological impact of the implant. In Figure 6, we can see under the experimental clinical evaluation that the implant is exposed, especially for the soft diet group, and that for both groups there are experiencing redness, plaque accumulation around the cemented area, and inflammatory bone loss. The microtomographic scans in Figure 7 give us a better look into areas where we experience bone loss. 14 days after the cement application, we can see how there is bone loss at the cement application site on the right when compared to the pocket control site on the left. When putting this analysis into graphical representations that we can see in Figures 8A and 8B, there's a significant difference in linear bone height for the implant with cement for the soft diet group versus the control sites of the soft diet group. Then for the tooth separation of the first and second molars, there was no significant difference between the soft diet experimental group when compared to the soft diet control group. Although for the hard diet group, there was an even greater significant difference for the implant and cement site when compared to the control sites for both the linear bone height and tooth separation. The major takeaways from this analysis are that linear bone height implant data expresses the negative effects of dental cements on osseo-integrated implants, while the tooth separation of the first and second molars that are adjacent to the cementation site indicate the influence that dental cements have on surrounding periodontal tissues. To conclude, residual cements not only affect peri-implant tissues but can also impact periodontal structures adjacent to the implant. So we must take careful consideration to the use of dental cements with implant prosthesis. Next is to conduct further microscopic and molecular studies, which will allow us to investigate and develop more clinical methods to treat periodontal diseases, as we will then have an even greater understanding of the mechanisms of the residual cement-associated peri-implant diseases. I would like to thank you for your attention and all the home lab members for their support.